About that.
No worries.
Great. I'm going to just start, even though we only have a few folks in, and I'll keep monitoring. Okay, welcome to the participants that are just joining us for breakout session 1. We are doing a skill building workshop in this session, and the title of the talk is Caring for the Whole Person, LGBTQ+ Care Planning in a Pandemic. We have 2 great presenters with us today. We have Kelly Rice, who's the Program Manager, Howard Brown Health, and we have Jacqueline Boyd, the CEO of the Care Plan. I'm going to go ahead and turn the presentation over to them.
All right. Good morning, everybody. Great to have.
Sorry about that.
Great to be with you this morning for our first session. It was a really great keynote, and I'm ready for a great rest of our day. So let me go ahead and share the slides here. Just to share as well, as far as conflicts of interest, both for Jacqueline and I, no relevant relationships to disclose there, and we had no commercial support for this presentation. Again, my name is Kelly Rice. I have a Master's of Public Health from DePaul's MPH program. Use she and her pronouns. I am the Program Manager for Intensive Community Care Services at Howard Brown Health, which is a federally qualified health center here in Chicago. And I'll let Jacqueline introduce herself.
Hi, everybody. It's so wonderful to be with you. My name is Jack Boyd. My pronouns are she, her, and they, them. I'm going to put up on the screen a nice contact info in case you would like to reach out to either one of us for additional information. I'm the founder of a company called The Care Plan here in Chicago. We provide care planning, care management, and professional education services from an LGBTQ+ perspective. And so we work with folks, anybody over the age of 18, to improve their health and wellness. So there's my contact info, and we'll share that again at the end. In general, we want to be sure that, it is Friday, in the midst of an election week, in the midst of a pandemic, in the midst of a racial reckoning moment for our country. And we know that you are carrying a lot. We know that the days have been challenging, and it can feel like an emotional roller coaster. So in this space, we want to be sure you take care of your needs. If you need to move around, take a break. If you need water, food, just to breathe, take care of yourself in this space. We want to hear from you, right? Kelly and I are going to be sharing our experiences, and we know that you as practitioners and leaders in the field also have knowledge and experiences that your peers can learn from. So please do use chat. We'll have plenty of time for Q&A, and there are points where if you have something to share, feel free to reach out, and hopefully we can hear some of your voices today as well. And we wanted to acknowledge that we center the voices and experiences of those most impacted by COVID-19 and the racial reckoning moment we are in, specifically Black, Latinx, Indigenous, disabled, and LGBTQ+ folks. Kelly, do you want to move us through the objectives?
Definitely. So there's a few key areas that we really wanted to spend some time focusing on today. The first was to reflect on the effects of the COVID-19 pandemic that we're living through, as well as the George Floyd related protests and the impact on LGBTQ older adults. Also to explore how we can best care plan with LGBTQ older adults during this time. And then just hopefully share some tools and resources to help you better support holistic wellness for this community as well.
We wanted to be sure, in case anyone is coming to this topic for the first time, to make sure you're aware of what we mean by this acronym when we say LGBTQ+ communities. We're talking about lesbian, gay, bisexual, transgender, queer, and the plus means the many, many other identities that are under the LGBTQ plus umbrella. It's important to know that when we're talking about these communities, that we're talking about people with many different identities that live at many different intersections. And when there's a distinction between sexual orientation and gender identity. When we're talking about sexual orientation, we're talking about who people are attracted to. So that's an external orientation. When we're talking about gender identity, we're talking about who people feel themselves to be internally. Each of us has a gender identity and a sexual orientation, even if you've never thought about it before. As a practitioner and as advocates, it's important to remember that the LGBTQ plus person in front of you has their own journey. There is no one way to be LGBTQ plus. Likewise, the language, culture, and needs of LGBTQ plus communities changes frequently. And so this is one of the reasons why I love working with these communities, because there's so much resilience and adaptation that happens. And if we were to do a session that expanded on terminology, we could really be here all day, because there's so many ways now to claim identity and to name people's experiences. So if you ever feel a little overwhelmed or like you're behind the times or don't know what some of these terms mean, don't worry, you're not alone. Thank goodness for Google and for LGBTQ plus resources that are out there to help us stay on top of things. We wanted to acknowledge really what's happening in this moment, right? That we are in the midst of this global pandemic. Many of us, especially in the Chicagoland area and in urban areas, have experienced increased violence and unrest in our communities. And that often is happening in Black and Brown communities. And so the state of the world has changed from the time of this conference last year. It has required us to change as providers. And it's just important to recognize that we are, as providers and as people who are seeking justice in the world, that we are in a position where we're seeing clients with higher acuity. We're seeing people struggling in a way that maybe we didn't years before. We're having to adapt to how to provide services virtually and how to keep ourselves and our clients safe in the process of accessing the resources they need. The reactions that people are experiencing, both us as providers, our clients, and our wider communities, are really, really varied. That's part of why we encourage you to take care of yourselves in this space. Even if you don't have that ability or encouragement in other areas of your life, we recognize that you may be holding many of these emotions at the same time, right? And the same is true for your clients. So it's important to acknowledge that people have been experiencing a higher degree of trauma than we've seen in past years, and that we collectively may be in and out of some of these emotions and some of these areas of feeling productive, rested, connected, optimistic, all the way to fearful, angry, anxious, depressed, isolated, hopeless. So wherever you're at, we validate your emotions and are grateful that you're here with us today. And whatever the challenges that you're having around care planning or the specific issues you're struggling with LGBTQ plus communities, this is your time. So please use the chat. Please let us know what your biggest challenges are, and we can speak to more directly to your needs. Both Kelly and I come from a perspective of trauma-informed care. It's important for both of us in working with vulnerable populations, and in particular, LGBTQ plus clients and older adults have seen vast change in our society. They lived through a time where it was barely known that you could use the word gay, and people were targeted for arrest for being kicked out of their homes or not rented to or sold homes to not being hired for jobs or experiencing clear and open discrimination in professional settings. Kelly and I both have heard numerous stories from our LGBTQ clients of the ways that systems that were supposed to help, including healthcare and mental health systems, were not safe spaces for them. So we as providers think about, in our one-on-one interactions, in the programs we design, in the services we provide to community, even in our marketing materials and outreach materials, we are thinking about everything from a trauma-informed lens. How can we create environments where people feel safe, where they trust us, where there's collaboration, where there's choice, and where they can feel empowered? So that means that we see ourselves in the care planning and care management process and any advocacy efforts as being in collaboration with our clients. We are alongside them in their journey, not ahead leading the way and telling them what to do, and not behind pushing them in a certain direction, but authentically in collaboration. And I think that's one of the critical pieces of working with LGBTQ plus populations. But again, really working with anyone in this time, it makes sense to expect that people are experiencing some degree of trauma, that they may be feeling unsettled and stressed out, and that talking with you or working with you, they may be bringing some of that anxiety and stress and past trauma to the conversation, which requires us as providers to really take a step back and be in a position of authentic support. As we've been discussing, many of us as providers may be feeling burned out, or you may have a stress level that has risen to the level of secondary or vicarious trauma. It is so important that if you are feeling any of the symptoms of secondary or vicarious trauma, that you are really assessing where you're at and trying to address those issues, right? So these are some of the signs of secondary traumatic stress. And in sharing these, I want to also have a caveat that we're not saying these are all related to secondary traumatic stress, but if things have changed for you in these areas, it's something to look at, right? If you normally don't have nightmares or flashbacks and you're starting to have them regularly, or you can't get a client out of your mind and it is making you depressed and sad and worried all the time, if you're preoccupied or exhausted, if you maybe use substances at a certain level and now you find yourself using them at twice that level, if you're not wanting to be intimate with your people, if you're denying that you have problems, or you're having physical ailments that have no source, these are things to look at, right? We can't do the work and we can't advocate fully if our tank is low. So if you're experiencing secondary traumatic stress, I encourage you to reach out and discuss this with people that you trust. You can also reach out to Kelly and I, and we're happy to provide you with some additional resources. Kelly, would you like to take over from here?
Definitely. So I guess too, feel free to pop questions in the chat box as well, so we can just kind of have those conversations as we go through as well. So just want to share a little bit of information regarding the populations that we're talking about, and to give some information around that as well. Statistics around the LGBTQ populations in the United States and internationally, we don't have really great data. We've just recently really started systemically collecting sexual orientation and gender identity data. So we definitely think that these numbers are underreported. But in 2011, it was estimated that there were about 2.4 million lesbian, gay, bisexual adults over the age of 50. And that by 2030, that was expected to double to about 5 million people. And in 2016, with the national survey, it was identified that about 217,000 adults 65 or above did identify as transgender. And we know that there are pretty significant health disparities that exist between heterosexual and cisgender older adults and their LGBTQ peers. So this is just one measure that shows that. So looking at self-reported disability, about 35% of heterosexual older adults nationwide report that they do have at least one disability. And that moves up to 47% for lesbian, gay, bisexual older adults. And then it rises even higher to 62% for those that identify as transgender. So almost a 30% increase in disability rates from cisgender to transgender older adults. We also know that especially for, some of this is generational, but especially for our current older adults that identify as LGBTQ, we know that they are 3 to 4 times less likely to have children. Almost 80% have reported that they have gone into the closet when they have had to enter a long-term care facility or a nursing home due to fear of discrimination and abuse. They're twice as likely to age alone. And there's really just an invisibility, stigma, and discrimination that exists within the health and aging systems as a whole, which can make that environment feel pretty hostile for older LGBTQ adults. These are some top concerns, and just want to stress that these are pre-COVID, and these were major issues pre-COVID, and you know, post-pandemic are much higher concerns as well. A lot of LGBTQ older adults report a higher level of isolation and loneliness, and having difficulty finding that community that many older adults rely on. They don't have that traditional family safety net as much as heterosexual peers, as well as looking at, you know, the senior centers and some of the other community supports may not be a welcoming and inclusive environment. Housing, we know, is a huge concern, especially here in Chicago, being able to find affordable, accessible, safe housing. Financial concerns, especially for older LGBTQ adults, they tend to have, that population tends to have a much higher rate of living in poverty and also facing lifetime of discrimination. And so for many folks, that Social Security that many people rely on may be less, or they may be relying on SSI. You know, which is about $771 right now to try to pay for all their expenses. So that can be a huge concern, how to pay for medications, how to pay for all of your daily needs. Care support as well. So being able to find services to provide care where you feel safe, you feel welcome, it's an affirming and competent provider can be much more challenging for LGBTQ adults to try to seek out. Same thing within the healthcare system as well. Especially if individuals have experienced discrimination in the past or have experienced poor care based on their identities, that can really impact their ability to access those services and their willingness to enter those services.
Kelly, do you mind if I just say a few words about the housing piece in particular?
Yes, for sure.
Okay. Hi, everybody. I just wanted to share, you know, if you think about where LGBTQ plus seniors are, this is a way that things change generationally, but we still have so far to go. So in the beginning of my career, I was 18 years old working in nursing homes, and through, I would say, the age of 30, was in aging services, never once heard LGBTQ plus folks mentioned in any doctor's appointment, in any senior housing. It just was not talked about. And so the clients that I met during that time, and these are folks that are, you know, now 70s, 80s, 90s, and 100, didn't use the term gay, didn't use the term partner. They used terms like, this is my friend, or this is my roommate, because I feel like aging services is about 30 years behind the general population in terms of culturally informed language and care and an approach with LGBTQ plus folks. So LGBTQ seniors have been very invisible within senior systems and retirement communities. And if you think about a senior even aging right now, maybe somebody in their 50s, 60s, or 70s who's saying, okay, I'm living in this 3-story walk-up, I'm on a fixed income, I can't be here forever and I need some more support. There's only 2 housing outlets for them in the city of Chicago. There's Town Hall Apartments and there's Pennycuff Apartments, which are going up, both of which are independent living. So what happens to that LGBTQ senior who may not be able to get on that list, right, for housing, because those lists are often closed and have waiting lists, who aren't sure about how they're going to be received when they do move into senior housing? It's so important for us to really understand the magnitude of these very basic needs that we all have, that our seniors are at a real crossroads with and are struggling with. So there's a number of things that both Kelly and I do around advocacy, which is a lot of training with senior institutions, and also we are working on an intergenerational LGBTQ plus housing project in Chicago called One Roof Chicago, that will help both seniors and young LGBTQ people come together to have a more normalized home environment where you can have those intergenerational connections that so many people need, right? So oftentimes we think about housing just as shelter without understanding the importance of being able to be yourself and have that quality of life experience. So I could go on and on about all of those areas, but I think housing is a place where, if you don't know where you're going to lay your head, if you're not sure that you can be out and share part of your identity, then it makes your housing situation feel unstable the whole way through. The staff can be as nice as they want to be, but if you can't share who you are, then you're not going to feel safe. So that's enough of me preaching. Kelly, I'm passing it back to you.
All right. Just wait for this to pop back up.
There we go.
Okay. Yeah, we wanted to show some of the impact that COVID is having on the older adults living specifically in Illinois. So this is data that I pulled from Illinois Department of Public Health, looking at the confirmed COVID cases by age and race. So if you're looking at the graph there, what you're seeing is, the majority of COVID cases are really between the age groups of 20 to 59 is where we're seeing the bulk of people coming in that are testing positive for COVID. But if we flip to the next slide, you see a very different picture. So this slide is confirmed COVID deaths by age and race. So if you're looking at this, the mortality burden is really held by older adults age 60 and above, but especially for folks at 80 and above. And so this is where we're seeing, some really strong disparities among outcomes between younger adults and older adults. And before I kind of speak to this slide, I also just wanted to share as well that we also are not able to really provide any data as far as the impact on COVID on sexual and gender minorities. That is something that most states and on a federal level, that it's information that's not being collected. I know Pennsylvania, their public health department has made a very focused effort to make sure that they are collecting that data. So we should have some information coming out from Pennsylvania as far as how COVID may be impacting sexual and gender minority populations differently. But it's not something that we can really speak to, which is unfortunate as well. Those outcomes and those disparities are just going to kind of be invisible at this time until we change that. But we do know that there are some pretty significant disparities related to race. And so what this is showing is CDC data. It is from February to August, showing the death rate per 100,000 by age, race, and Hispanic origin. So if you're looking at people age 65 to 74, non-Hispanic Blacks were 5 times more likely than non-Hispanic whites to have died from COVID. And at each age group that you're seeing, there are pretty significant disparities between the death rate, even for those 85 and older. Black older adults are at that age are twice as likely to die of COVID than their white counterparts. Also, just kind of bringing it to a larger systems level, Kaiser Family Foundation and the Undefeated also did a survey of adults. They interviewed about 1,700 adults, and about 777 identified as African American, and this was between August and September of this year. So one of the things that they had asked was, generally speaking, how often do you think that our healthcare system treats people unfairly based on their race or ethnic background? And you can see some very significant differences amongst the respondents based on race. About 31% of Black or African American adults felt that these systems treat people unfairly very often. 39% felt somewhat often. And it's a very different view there based on if folks identify as Hispanic or white. One of the concerns as well is that these thoughts about being treated unfairly are growing as well. So this similar question was asked in 1999, and about 56% of African American adults said that they felt very often or somewhat often that they were treated unfairly, and that has risen from 56% to 70% this year. So it's an issue that's growing and not getting better.
Kelly, I'm sorry, I was going to ask, would you mind sharing kind of your perspective, if you feel comfortable, within healthcare system and what your clients tell you about the experiences they've had within healthcare systems? Because I know, you Howard Brown in particular works with folks across the city in a way that not many healthcare systems do. So just curious if you have any anecdotal information to share.
Yeah, definitely. I think that it's one of the things that we do hear a lot. One area where I hear a lot is around pain management, and people reporting different experiences living with chronic pain and trying to access care for chronic pain. Being refused pain medications, and really seeing some differences based on someone's identity. So whether that is their race, whether it's their ethnicity, even with gender, we see that. We hear from more women than men being refused pain medication or being seen as drug seeking when they're asking for support around that. I think the same thing around, we see that with pregnancies as well, and the differences in support people get regarding their health care during a pregnancy when they're reporting symptoms. So it's something that we definitely do hear quite a bit in a lot of different areas. And also based on socioeconomic status as well. That's something that we've seen on a pretty regular basis, where folks that are coming from a lower socioeconomic status, again, are treated as they are drug seeking, or their pain is denied, as opposed to those that are coming in that may be presenting as a higher socioeconomic status and being given that care. Even the speed of care as well. There's been studies done on that as well, where men going into an emergency room seeking care for pain, that pain gets treated much faster than it does for women that present in the same spaces. And if we go to the next one as well, this is from that same survey. So this is looking at, do you trust these institutions to do what's right for you or your community almost all or most of the time? And some of these areas, I think, are not a surprise to anyone. If you look to the right, where there is the police system and the court system, I think those responses are what we would expect. I think what's concerning is looking at doctors, local hospitals, and especially when you look at healthcare system, and especially for most of us as public health providers, looking at a systems level, seeing that the rates, even for white identified individuals, is pretty low as far as trust in our systems to be able to do what's right for our communities. It is relatively low, and so that's definitely a concern and something that we need to address if we're trying to address care and health at a public level. How do we transform these institutions so that people do feel that they're safe, that they are affirming, that they're welcoming, and that they are going to do right by them when they are in need.
Kelly, do you mind taking over sharing the screen? Thank you
Of
so
course.
much.
Mm-hmm.
So now that we can see the data, see what's happening around COVID-19, see how it's disproportionately impacting um, Black and Brown communities, and I can speak to this from a from personal experience as well, because in March, it felt like on my Facebook page about every week there was a Black lesbian, a Black woman, a Black queer person who had passed without notice, without a diagnosis of COVID, because they weren't testing at that point. But we saw it happening very early on in the pandemic. And so, I can't underscore enough how much we don't know, and how much distrust there is within many of the communities that Kelly and I serve, when it comes to talking to providers. This is really one of the major challenges and barriers to doing care planning at any point in time, but especially in a pandemic, is people don't know if they can trust us. And so that trauma-informed approach of saying, hey, how can I bring my best, most present self to this conversation? How can I make sure the person across the table from me is comfortable? How can I continue my education so that I can, as much as possible, have an understanding of what they've been through so that I don't recreate trauma? And so I help them continue to process those experiences and build trust in a healthy way. I think one thing that is so important to be aware of is how LGBTQ plus communities have been impacted over the last 35 years by HIV. And I have the term legacy in this slide, but honestly, it's still so active, and still are, in particular, Black and Brown, same gender loving men, young men and young women are at a high risk. So it's important to remember that the seniors you work with may have been through a lot of grief and loss and trauma because they lived through the height of the epidemic. They lived through the time when they felt like they lost half of their community. So that's part of the reason why we have fewer social supports. It's part of the reason why people are sometimes hesitant to talk about aging and to talk about end of life, because imagine going through what felt like a war zone in your 20s and 30s and not having any resources and being targeted and discriminated because of HIV. So it's important for us to remember that when we're having these conversations, that may be in the back of somebody's mind or at the forefront of their mind. So I just wanted to share that perspective. We can move to the next slide, Kelly. Thank you. Kelly and I were so excited to have this conversation with you all and to do this workshop because, oftentimes in public health and in social services, there's a pathway, right? We're talking about an evidence-based approach. We're talking about frameworks and theories. But what both Kelly and I are super passionate about is, how do we care for the whole person? How do we put people before process? And I think that's a constant, it's, at least for me, what keeps me fired up and passionate about making change in healthcare. Because if we're supposed to be helping people, we can't do that if we're so specialized, we're only looking at one part of the person. We have to take that holistic, comprehensive view of what's happening for them on the social level, right? You remember that's a top priority for seniors in general and for LGBTQ seniors. I could be sitting talking to a senior about, well, we probably need to get this checked, and we need to work on housing, and we need to get, I want to figure out your SSI. Like, there can be a million tasks that we need to accomplish. And the primary issue is, I'm lonely. I don't have anybody. I don't feel like I belong, and I feel like I've been forgotten. So if we don't address those social issues, the medical issues, the legal issues, the financial, if it's not the client's priority, it's not going to be successful, and they're not going to feel good in the process. So keep in mind, whatever your job, whatever your role, there is a whole person sitting in front of you that has their own history, their own passions, and their own priorities. And so that's always the reminder I give myself as an advocate is, what's my role in this person's life? It's not ever to tell them what they need to or have to do. It's to better understand what their motivations are, what their needs are, and how can we increase safety, increase their quality of life. So these are just things that we think about. And I think it's also important, Kelly, if you want to share your perspective on this. I love the way you talk about advanced planning as being about as much about more, if not as much as about life as it is about death. Do you mind saying a few words about how you think about that part of care planning?
Yeah, most definitely. Yeah, and I think that's one of the hesitations that a lot of people have in wanting to do advanced care planning or to create those documents, is that folks are thinking about it's about my death, it's about my funeral, or about like those after pieces. But it really is about your life. It's about, what do I want the next 20 years to look like? What do I want my care to look like? Who do I want around me? What, my support system? What are the values that drive me? What are the things that make a good day a good day? And things that I want to have included. What are some things that really go against my values and would negatively impact my life? And so being able to have those conversations, I think, can just be so enriching and so empowering, because I'm making those decisions. I'm not leaving them for somebody else to make them for me. And just a couple of really brief pieces to that. When my grandmother was diagnosed with lung cancer several years ago, we did sit down to do advanced care planning, and it was my grandparents, my parents, and myself and my 3 siblings. And we all sat around one table and we all did the documents together. And we were a very tight-knit family. We were raised with our grandparents and our parents. And it was so interesting to me to sit around a table and to hear every single person had such distinct choices that they were making about what they would or would not want done in their care. So it's, even though you are really close to somebody, it doesn't mean that you know what that person wants. And so just to kind of anticipate that, I may, Jacqueline, my power of attorney, she's going to know exactly what I want, not necessarily so. And I think it can also, to me, as somebody that just loves to learn from other people, it can just be so enriching as well, just to hear other people's thoughts and values, experiences, traditions. We've hosted, and we'll share a link to it later, some death over dinner events as well. And with those, being able to sit down with others and, what was your family's experience? What's important to you? And being able to have those discussions and learn from each other can be pretty amazing as well. So it doesn't have to be a doom and gloom conversation. It can be a really empowering and fun one to have.
Yeah, and I'm such a nerd about this stuff. I really love these conversations because it all comes back to choice, right? And seeing people go through kind of the healthcare machine and where choice is taken away or where it's left on the table has made me super passionate about all of this. So only about 33% of Americans have their advanced directives done. I'm 37. Mine were done years ago. I'm like, nope, nobody's going to be making these decisions. I love my parents, but they're not automatically the people that know me best and will advocate most effectively for me on the healthcare front or on the financial front. So, we each deserve to be careful about who we choose to speak for us and to advocate for us. And one of the ways that I really like to think about the pathways for LGBTQ aging is it's an open field, right? This is the first generation and generations to age out. So there's not necessarily a bunch of role models or a clear-cut path. So what happens if we say, well, why don't I have a care planning conversation once a year with my friends, my chosen family, and we can just talk about our health, talk about our goals, talk about what we want that last quarter of life to look like. I always say, aging on accident, you don't end up always with the experience that you want, right? If I think about the costs of care alone, and that a shared room in a nursing home in Illinois right now is $92,000 a year, aging is going to be one of the most expensive endeavors we undertake. And I don't want to be making that decision from a hospital bed because I'm giving choice away. I have had no time to choose really where am I going to be comfortable for the rest of my life if I need to be in skilled care or long-term care. So, I think these conversations, and we'll share more strategies, but take your time. Take your time. It may take a while for your clients to even be comfortable having these conversations, but that's not a reason to leave choice on the table. So that's where we're at on just sort of how to think about the whole person while you're trying to have these conversations. It's important also to recognize, again, what LGBTQ plus seniors in particular have been through and try to understand their perspective. So again, there's no one story. I certainly have met clients that don't feel any of these things and are, kind of on the opposite end of the spectrum saying, well, I have a really clear idea of what I want and I'm going to make it happen. But that's by and large not the typical client that we work with. So these are often the personal beliefs and experiences that are at play when we're doing care planning or when I'm meeting a client for the first time. Many LGBTQ seniors feel forgotten by the community, right? They're not sort of the center of attention. They're not getting the recognition for all of the efforts they have made through the last 5 decades and 6 and 7 decades to move LGBTQ plus rights forward. They feel forgotten and sidelined, even in community spaces. Oftentimes people are, seniors may be to the side or kind of sitting at a table by themselves and not as connected in a community setting. Many people live through the HIV/AIDS epidemic, the height of it, and have trauma from that. This next bullet point is one of my favorites. As a queer woman, I love when my lesbian community tells me, "Oh, well, I have a partner. I'm going to be fine." I'm like, that's not a plan, friends. Unless you have made a pact to both pass at the exact same moment, you're leaving choice on the table and somebody's going to be left more vulnerable. So really helping people think through how do you love and care for each other intentionally? And that means taking care of some of the practical pieces and legal protections. Talking about this stuff is depressing. Again, to Kelly and I's point, it doesn't have to be. It's all in how we approach it, how we explain it, and giving people the time to get used to the idea. I don't want to be a burden to anyone. This is huge. And I know many of the seniors we work with and many of the clients you all work with have this same feeling, right? Our culture and society is very ableist in that our bodies and our minds are worth what they produce. That is internalized for so many of us. So it's really important to try to work through some of that perspective and internalize ableism to say you are of worth and of value just for being who you are and just for existing, and you deserve care because you are a person in the world. The way that I help reframe this particular issue for my clients, because LGBTQ folks are again, they're more likely to be mentors and activists than non-LGBTQ folks. So this bullet point is one that's really important. I'll reframe with my clients by saying things like, I hear you. You're an independent, strong person. You have always, made your way in this world. Would you show up for a friend if they were in a similar situation? Would you help them out? Would you want to support them and support their wellness? Why don't you let your friends do that for you? Or what's stopping you from letting your friends support you in the same way? Trying to reinforce the strength of the relationships they do have and help acknowledge the strength of those relationships is oftentimes one of the first conversations we need to have, because it comes up oftentimes in the form of like depression or anxiety. People will say, well, I don't have anybody. There's nobody that can help me. There's nobody that can do this, that, or the other. And so we have to circle around to, well, who do you spend time with? Who do you see? Who do you trust to get more at the specifics of who can be part of the care planning process and who their family or chosen family truly is. Young and changing caseworkers, it's really hard because people who have been sort of overexposed to institutions may be tired of talking to, folks that are significantly younger than them that change every 6 months to a year. So that's very reasonable. It's nonprofit fatigue. So that makes a ton of sense. I don't have anything or anyone. I think I already spoke to this piece, but these are some of the internalized barriers that you'll want to be aware of with your LGBTQ plus clients.
Yeah, I just wanted to add with the I don't have anyone or anything kind of piece. That is something that we encounter a lot when we're doing advanced care planning, especially with the older LGBTQ adults that may not have that traditional family member or partner that they would identify as a power of attorney for healthcare. And that's where it is really important for us as practitioners and as systems to really be able to support people and actively engage in the advanced care planning process with these folks to help identify if there is somebody that they can kind of bring into their support system that can speak to them. If someone ends up in the hospital, is not able to speak for themselves, and they don't have kind of like those built-in folks that are on that surrogacy list with the state as far as who can speak for them, it's going to be a hospital ethics board. It's going to be people that have no connection to that person and no idea of what that person wants. And so, again, just with being able to control what happens to folks moving towards that time in their life, it is just so vital as practitioners that we are able to really help people engage in really active care planning before it becomes a crisis situation.
Absolutely. So I'd like to pause here. We have about 20 minutes left, and we're a small group today, so I think we have plenty of time to check in and ask questions. And if you have experiences that resonate with what Kelly and I have said or are different, would love to hear from some of the participants. So does anybody want to speak up and share how care planning has been for you within LGBTQ plus communities or just with your clients in general? Maybe Yvette, Katie, Marissa, Sally, anybody want to speak up? Hi, Marissa.
Hi. Sorry. There we go. I'm currently not, I used to work in a hospital, and so everything that you're mentioning, it is pretty familiar. And it was, I don't have too much experience with the LGBT community, and that's the reason I'm here to learn more. But in general, it's something that a lot of the patients that I work with didn't plan for. Like, you would ask them, do you have advance directives and stuff like that? And it was like, something. And that was an eye-opening for myself because I started thinking about myself as well, something that I haven't done. So for sure, it's something that we need to advocate and inform and educate, ahead of time. And so it's very interesting.
Thank you so much for chiming in and for your years of work in the industry. It can be a challenge to see these problems and not always be able to advocate within institutions or, create the change that we want to see. But I think your comments also speak to just how important it is that we continue learning and that we continue being curious about different populations. Because if we're doing it right for the folks at the margins, it feels better for everybody, right? If we are taking this trauma-informed approach, if we are giving more time to our clients or patients, if we are not making assumptions, then that works better for everybody, right? Not just the folks that we're learning about in this session. So really appreciate your comments. Thank you so much for sharing. Anybody else want to chime in and either build off what Marissa said or share some of your experiences? Not everybody all at once. It's overwhelming. All right. Well, we'll continue to get back into the care planning strategies.
You're muted, Jackie.
I was saying such interesting things. Okay, so let's talk about really how COVID-19 and this year has impacted how we deliver services and how we advocate. Obviously, we're primarily virtual, right? Even those of you who may be working in medical systems, there's probably a stronger telehealth element than there was before. There's certainly more distance, whether we're talking about distance virtually because you're seeing clients with telehealth or over the phone or Zoom, or because you have to keep that distance even when you're in person. So virtual care planning and service delivery has created space and also unique opportunities when care planning with LGBTQ elders in particular. I found that with some training, with the right materials, right? If we need to get somebody an iPad, or if we need to find some online tools to make sure that they can see the materials that I'm sending, whatever we can do to train around the technology, it can really help to increase that connection. And honestly, if you have a client who is dealing with chronic pain or has mobility issues, we're approaching that never-ending Chicago winter. Being able to have these virtual options as access points, I think is it's a good addition. It's good for us to get in this habit so that we can meet people where they're at and not expect folks who are in pain, have mobility issues, or on a fixed income to spend the money to get from their neighborhood to your location. So the virtual care planning and service delivery has really changed things. It also does mean, at least for me, that I need to allow more time for sessions. So whereas you might be able to sort things out clearly and quickly in person, the tech delays, the sound, the understanding, and that automatic rapport that can happen sometimes is more challenging with seniors because they're just less used to this interface. You know, I don't know how you all feel, but for myself, being in my 30s, I'm able to, I can create the same intimacy and authentic connection with folks that are at that same level of tech savviness. But for seniors, and for folks who are not necessarily tech savvy, the tech causes a barrier. So these are things to be aware of, that if you're having these sessions or these care planning moments, it may take 15, 20 minutes to create the rapport to have those meaningful conversations and to dig deeper. There's more mutual aid programs, both formal and informal. So there's ways that people are trying to support each other that kind of harken back to the way care used to happen, right? Where we knew our neighbors and we knew the seniors in our community and the vulnerable folks and brought groceries or did their yard work or, you know, did their dishes a couple times a week. We're seeing a lot more of that. So in some ways, seniors might have access to more support in their communities. It's not promised, but we're seeing some of that happening. So that's a change that I think is going to be around certainly through the end of the pandemic and hopefully beyond. We are also seeing increased socialization needs. So again, this is an area of concern for most seniors, and folks are even more vulnerable. I'll give you an example. We have a client who just passed away recently, but she was a fighter. She was butch lesbian from Calumet City, basically had to fight her way through life her whole life. She lost her partner about 4 or 5 years ago, and she's been living in senior housing. She was already somewhat isolated. She, you know, had folks she was friendly with, but it wasn't enough because she was really missing that intimate connection with her partner. In the course of this, she got so lonely. She started losing weight. She became more depressed than she already was. And I think she stopped taking care of herself. And so one of the things that we did was we sent her, we were like, okay, what would help with the socialization? Because we can't get to her. We can't come see her. We can only see her through a window. So we sent her a robotic cat that she just loved, because they make them so lifelike now that you just feel, it's close enough that it's comforting, and it helps with that loneliness. So that was just kind of an example of an outside the box approach to how to support those socialization needs. But I've also seen clients and family members take their loved ones out of senior housing so that they can have that connection, and feel like they're providing a safe environment. I think we're going to continue to see fast evolution within the senior care industry and within healthcare to meet the demands of this time. Kelly, anything else you want to add about kind of what's changed in the last year?
No, I just think it is something that as a system is something that we really need to evaluate how we're currently providing care. Speaking to nursing homes and long-term care facilities, and COVID came, and it was in an attempt to protect vulnerable populations, but it was kind of like put everybody on lockdown, put everybody in their rooms, delivering meals to their rooms, things like that. And now we're really seeing the negative impact from that as well, and looking at death rates for causes of death that are not related to COVID are much higher this year than they were at this time in previous years. And they are relating a lot of that to that decrease in socialization and the levels of loneliness, and how that can negatively impact our health as well. And so I think, around care planning, again, care planning is not just about your end of life and your death, but the rest of your life. And so I think, especially given this pandemic scenario, that it doesn't look like it's going away anytime soon, how do you want to plan for your care during this time, and what are your priorities? And what are the options that you do have, and really helping people to explore those so that they can still live as well and as positively as they can.
Well said, Kelly, and that's a perfect transition into how do we start this conversation. Because it can, depending on your role, it sometimes can feel awkward to bring up long-term care planning, advanced care planning, what people want to do if their needs or abilities change. So the first thing I would suggest is that if you aren't accustomed to having these conversations, that you practice, that you figure out what is your language. How can you bring your authentic and hopefully kind of casual self so that you're not feeling nervous or unsure, because your client will pick up on that. So, as an example, when I started my company, the first 3 months, I was figuring out, how do I do this care planning? How do I, what are the systems and processes I need? And I employed my family and practiced with them, and was like, I know that you have told me no on many occasions, but I really need to just practice having these conversations about advanced directives. Would you please sit down for an hour and let me practice with you? So if you've never done this before, if you want to sharpen your skills, employ your family and friends. It's a great way to advocate with them too, to bring home why this is important. And it also will help you feel more confident when you're in front of a client. And think about your language. These are some of the phrases that I use when I'm working with clients. I always, no matter what the situation is, always ask my clients, what are your top priorities? So that I can be crystal clear in my collaborative approach with them about what they care about. It shapes the direction of all those conversations. It shapes the way I advocate, and it helps build the relationship, because they know whatever your priority is my priority. What are your hopes and fears related to aging? What are the experiences you've had? Tell me a little bit about if you've been a caregiver before and what that was like for you. So it oftentimes I'll use motivational interviewing to help get at the root of how people feel, even if that feeling is, just not excited about having these conversations. I use motivational interviewing to kind of better understand where they're coming from, and to try to move the conversation forward. Would you, and I think consent is also really important. So I really think about these conversations happening over time. I am not in the first conversation with a client going to sit down and assume that we're ready to talk about their end of life decisions and the medical choices they want made. That's very presumptive of me. It's important to ask for consent and to say, hey, it's been so great meeting you and talking with you. I have a sense of what your priorities are right now. I wonder, because we take a really holistic, long-term approach, if you would be interested, I'd love to have a conversation with you about advanced directives and about just how to protect yourself on the legal front at some time in the future. Would you be open to that? So that you're leaving that space, again, from that trauma-informed perspective around choice and collaboration. So assume that it's going to take time. If they come into your office and they're ready to talk and they're good to go, awesome. But that 9 times out of 10 is not going to be the case. We're going to, I've had clients where it took a year for us to get that paperwork done just because it wasn't a priority for them and they were unresolved about why they weren't wanting to do that paperwork. Kelly, anything else you want to add here about how you have these conversations?
Yeah, just a few other things that I would add. You spoke for a moment about kind of past experiences, and that I think is really important. So helping people to explore whether it's themselves personally or people in their lives, like what has been your experience with serious illness? What has been your experience with death? And in those experiences, what went well? What are some things that you would like to take from that experience and include in your own planning? And what are some things that maybe didn't go so well and that you want to make sure that you're able to avoid yourself moving forward? I also think it's really important to just help people to explore what matters most to them. So is it those relationships and those connections that are most important? Is it your functioning that's most important? So how do they prioritize their values? Because that's really how the plans need to fit in and under what those values are. And the other thing I would say is, we're talking about how to start the conversation, but I think in regards to the conversation in general, you should be listening a lot more than you're talking. So there may be periods of time to share, can I share with you the continuum of care? Can I share with you what ventilation means, what CPR means, if you're having those direct conversations? But we should be just guides helping folks to explore, asking those probing questions to help people kind of think through what their thoughts are and asking and what as well. So if somebody's making a statement like, I don't want to be a burden, not just leaving it at that statement and saying, okay, because what's a burden to me is very different than what's a burden to anybody else. So what does being a burden mean to you? And then just kind of like really probing through that answer and just really helping people to get to what are those core values and how can we make sure that those are respected and honored in the plan that's created.
Thanks, Kelly. Thank you so much. And I just want to reiterate how diverse LGBTQ plus communities are. If I think about care planning with my white, gay, male, Gold Coast clients who have, enough money to retire and live 4 different versions of retirement, care planning with them and their life experiences and their priorities are vastly different than my client who is living in Lawndale, who is a Latinx trans woman who does not have many financial resources and is living below the poverty line and is struggling with housing. So it's just so important to not make assumptions and to listen to our clients and really prioritize their priorities. So just wanted to share again, there's not one story. And you'll have clients that are excited about care planning or are super clear, and it's a matter of doing the paperwork and helping them suss out how they feel about the particulars. Then you'll have clients that just aren't in that stage and need more time. So in general, here's to summarize some of the strategies we've been talking about and put it in writing for you. It's about affirming who they are. Again, if you're familiar with motivational interviewing, use those techniques. The seniors that you're working with might not have had somebody tell them they're doing a good job or that they're being really responsible for taking this step or thanking them for their time in years. That same client I was just talking about, the care manager from our company that was working with her told her, gosh, it was probably about 2 weeks before she passed away. She told her that she was proud of her for something that she had, for I think it was for the way she was getting through the pandemic. She was like, "I'm so proud of you." And this client started crying, and she said, "I haven't had anybody tell me they were proud of me in so long, and thank you for saying that." I mean, I don't think we can imagine and understand the level of isolation that happens for some of these seniors, and how much we matter to them, and how much what you say matters to them. So continuing to bring forward that affirmation, having clear and consistent communication, that is one thing that will derail a care planning process quicker than anything else, is if you say you'll call and you don't call, or if you say you'll get this paperwork done and you don't do it. When you don't show up or when you don't check in, it feels like a betrayal or a loss, and it erodes the trust. So that's really important. Consistency and consistent connection is critical. You also may be one of the few people in their lives that can monitor their condition. So pay attention to any red flags you see or any changes, right? If somebody is more confused in your session this week than they were last week, set up another check-in. Check in with them in a few days and see how they're doing. See if it was just a momentary thing, or if maybe they're dealing with some kind of, UTI or dehydration, or, something that they're not aware of that may be affecting their wellness. Notice if they're wearing the same clothes that they were wearing every other time you've talked to them. Pay attention to who they say they're around and what those interactions are like, right? I think one of the challenges right now in this new virtual world is, how do we assess for abuse and neglect? How do we stay in the loop about those things? So it's really, really important to pay attention to all those small signs of how your client is doing. Katie, thank you so much. It was great to have you and appreciate you being there. Katie had said, "Hey y'all, multitasking at work and have to step away. Thank you for sharing your expertise and for all you do." Same, Katie. And we said, focus on the critical priorities, always explain the why something's important. Give realistic time frames. Don't let folks down. If you can't get to it in this week, don't promise to. I always send things in writing for each of my clients, that where there's any memory impairment or any sign that they might struggle with remembering what happened from the previous appointment, I have a notebook. And every single time I write in the date, what we accomplished, and what our next goals are, so that they can have that for reference, not just to keep themselves oriented to what we're doing, but also to affirm, hey, I have a history with this person and they've been consistent with me, and it helps build the trust. Educate on technology, as we've said. It's important to discuss risk factors, especially with COVID-19. I'm thinking about this with my clients and trying to position it as, are the people you're trying to spend time with or connect with, are they aligned with what you're doing around COVID-19? Like, if you're staying in your home and you're not going anywhere, and your family invites you for Thanksgiving, there's some big decisions to be made. Do you feel comfortable? Are you comfortable with the level of risk? How are you going to keep yourself safe in that setting? Do you want to skip this year or propose a virtual option? So it's important to really discuss some of the risk that people are feeling around COVID-19 and not make assumptions. Don't shy away from having these long-term conversations. If you're not asking, there might not be anybody else who is. And care plan collectively with a support system or other older adult friends if possible, right? It doesn't have to be depressing. It can be fun. And bringing in that chosen family is really important for your LGBTQ plus clients. All right, Kelly, you want to bring us home?
Yeah, I was just going to share with that last point. Like I shared before, we used to do like death over dinner and have those conversations, but I think it's something you can do with your friends and with your family member virtually as well. Have a virtual pizza party, and maybe I'll show some links where you can get like just even some discussion prompts to get the conversation going so that you're sharing these things. Because because we can do the paperwork, but doing, it's those conversations that are really important, which is something that we'll talk about as well. So speaking to paperwork really quickly, I know we're kind of getting close on time. When we're talking about, especially healthcare focused advanced care planning, we're talking about a couple of different things. First is your advanced directives, which is a two-parter. So there is the healthcare power of attorney, which is where you're designating who is the person that you want to speak on your behalf if you are not able to. And the second is your living will, which really details out what do you want, what do you not want. Those forms are available for free on the Illinois Department of Public Health website. But there's also some other tools that are out there as well that are also legal in Illinois. One that's really great as well is called 5 Wishes. And that ties in those two documents, but it goes a little bit more in depth into quality of life issues and some more of like the comfort questions and the support questions that the legal documents might not so much. And the next is the POLST. So this is what people might have known in the past as the Do Not Resuscitate Order, or DNR. So it's physician orders for life-sustaining treatment. And this is really important, especially for people that have been diagnosed with a terminal illness or may have been given a prognosis of especially 6 months or less to live. And this really specifies, especially for first responders, hospitals, what life-sustaining treatment you do or do not want. So it's going to go through CPR, medically necessary interventions, and comfort care as well. So that's something that's really important. And there are a few other forms that are really especially important for LGBTQ older adults. One is the authorized visitation form. And so this is a form that if you were to be hospitalized, really designates who you want to be able to come into that space. So especially for folks where chosen family is really important, maybe there is a partner that does not have, there's not a legal relationship there, to hopefully navigate some of the issues that you might run into in a hospital. The other is disposition of remains and funeral arrangement instructions. And this is really vital as well for people to make sure that people are respected and honored after they do pass away, to be able to have their name displayed and used correctly, to be able, if they are going to have a memorial service, that the way that they, the clothing and the way that they are, their body, their remains are taken care of, honor who they were. There are tons of horror stories out there as well, and people that I have worked with that have passed away and families have come in, and just really, it was a sad experience to see this beautiful person be dishonored after they had passed away. And so these are really important forms just for people to be able to protect themselves as well.
Hey, Kelly, I'm just going to let you know we have just 1 minute left.
All right.
And I put in the chat about Gather, the dinner that's happening on November 19th. We would love to continue this conversation. Come connect with us. We host a monthly dinner, 5 to 7 p.m., November 19th, and the registration link.
Yeah, just really briefly, a couple of websites I would really encourage people to look at. And we can get these slides to as well. But Prepare to Care is a really great comprehensive planning guide for caregivers in the LGBT community. Includes a lot of worksheets to help you work through things. We talked about Death Over Dinner, Death Cafe. Those are some really great programs that you can do yourself with family and friends. And Compassion and Choices also has a lot of great materials on their website, also specifically around dementia. They have a dementia planner and some other items as well. And then I have a few books listed there as well that the last two are really specifically for folks that are looking to do advanced care planning, and they're really great practical guides for that.
And with that, I think we're at the end. These are some additional resources for you. There's our websites. I didn't see anybody with questions in the chat, but if you have questions, get at Kelly and I. Victoria, anything you want to say to wrap us up?
I just want to say what an incredible presentation this was. I learned so much, and I know this is something I think about, and I'm going to take advantage of some of these resources as well. The session is recorded, and the folks at the Center of Community Health Equity will be kind of cataloging the conference and making this available for people. So everyone stay tuned for that. And then